Really?
Then you're on the wrong one.
893-2297-3852.
Yeah, we'll just give it another minute and we'll get going. Yeah, I guess we can move forward. All right, good morning, everybody. Hope you all had a nice weekend. Here we go. So, all right. So this is a patient who presented with intermittent 2-to-1 heart block. And this is the electrophysiology study that was performed. What we're looking at here are all 12, extra, what do you call it? A surface electrocardiogram, sorry. And this is a Hiss bundle recording at the bottom. So the question being asked is, what is the finding? And what would you do about this? Now, you don't know the paper speed. Let's just say that the R to R interval is a rate of about 40. So why don't we ask Dr. Konzen what she thinks is happening here?
Good morning. So if that's the Hiss, when I see deflections in the surface electrogram, and say like the beat prior to where the arrow is, probably the QRS, I'm guessing. And then so
it's hard to tell from the surface much because it's such a fast paper speed, but it's certainly, you're absolutely right, that is the QRS.
So then seeing, but then like in the beat prior to that, or in the intracardiac sort of tracing, thank you. Prior to that, there's no deflection in the surface electrogram. And then
you don't mean prior, you mean after, right? You're talking about this beat, is that right?
That, yeah, after that, but then also
this one here. Okay. Yeah, I'm sorry I cut it off, but you can see that the QRS is kind of starting. It just, I foolishly cut the page off. So.
No worries. But I was actually talking about the very first one. So there's
this
like,
beat. Got it.
Yeah, no, there's nothing. So where the arrow is,
what arrow?
Oh, I thought we were talking about there was an arrow on the in
this
the middle.
Arrow here, or this arrow, or what are you talking about? Let me move it away. My card.
I was talking about the third beat in the tracing where there's an arrow pointing. I thought that's what we were.
This arrow here?
Yeah.
Okay. Yeah, well, that is an important arrow. But why don't we take a broader view? What are we looking at here? What is happening here? Why don't we look at this beat? This, there is 3 components of a Hiss signal. So what are we looking at here?
A P, like a
So yeah, it corresponds to the P wave, but what do we call it if it's intracardiac?
A.
Yeah, it's the atrial electrogram, which is for all watching here. This is the atrial electrogram, right?
Long.
And then what is this little ditzel here?
H.
Yeah, that's the H. And then what is this corresponding to?
That's the V.
Right. So we have an A, a small h, and a V. And somebody has been kind enough to measure the interval from the H to the V interval at 69 milliseconds. Is that a normal HV interval or AB normal, abnormal?
I think it's usually around 50, isn't it?
Yeah, it's 35 to 50 is usually the stated adult normal HV interval. And just for the sake of conversation, what does the HV interval typically represent?
Oh, HV is the is that like the
I think you're
infrahissian, like conduct.
Exactly. So it's like His-Purkinje conduction, whereas the AH is usually representative of what, Tulsi?
Sorry, a suprahissian, or yeah, a suprahissian or hissian.
Suprahissian or AV node, right?
Right.
Remember that we can't record the AV node directly on intracardiac tracings, only the low right atrium near the AV node, and then the His bundle, which we assume is immediately beyond the AV node. So
Mhm.
we assume that the time from the low right atrium, which is denoted by this atrial electrogram, and the onset of the His, that during this time period, we're seeing conduction through the AV node, even though we don't actually have a recording of the AV node. It's one of the interesting findings about intracardiac EP is that we actually cannot, in a standard EP recording system, record AV node signals. Although, I've mentioned this many times, I was told when I was a fellow that if you were in a completely electrically neutral room, you could potentially do that. But the bottom line is, in clinical work, you cannot record the AV node. So you can record the low right atrium or the high right atrium near the AV node, and then and the time it takes to go from one to the other would be the AV nodal conduction time, and then the His to the R wave, which would be the V wave, which would be consistent with His-Purkinje conduction. So this is a patient who has infrahissian disease of some sort because the HV interval is 69 milliseconds, which is substantially longer than it should be. And I think even though I haven't measured the AH on this, I think we could agree that the AH is maybe a little longer than the 69, but not profoundly longer. And a normal AH interval, we remember, is anywhere between 50 and 150 milliseconds. So I think we could agree that this interval is probably, if this is 69, this is probably going to be under 150. So the AH is normal, albeit on the longish side, but the HV is also is long. So what's going on this next beat where someone has nicely placed an arrow?
Yeah. Um, is that um would that be like an escape beat?
Well, you're seeing so this is actually pacing. So this is a pacing spike. This
I
is
see.
an A,
Yeah.
His, a V. So here's another pacing spike. What is
His.
this?
That's the
No,
hiss.
well, it's the
Oh,
His
that's
channel,
the
but remember, pacing spike, A, His, V.
oh, gotcha. So
Pacing
that's the
spice, A, and what is
A.
that that the
It
arrow is pointing at?
should be a hit. That's the hiss.
Right, that's the His. But what is,
Mhm.
as we say on Sesame Street, what is different between this and this, right? Is we're
There's
missing.
no V
What are we
after.
missing?
There's no V after that.
There's no V, exactly.
Yeah.
Exactly. So we have AHV, and then we have, or paced AHV, and then we have paced AH and no V. So where
Yeah.
is the block? If we are conducting from
Gotcha.
A to H,
But not H to V. It's infrahissian.
it's infrahissian. And then on the next beat, it seems as if it's conducting, right?
Sure. Yeah.
AHV. So it does appear as if, at least in these three atrial beats, and again, apologize for not giving a longer strip, but it appears as if there's like 2-to-1, right? Because this
Yeah.
A-paced complex does conduct, albeit with a long AV time. This paced A complex does
It's
not
not.
conduct.
Yeah.
Then again, it conducts. And so
Sure.
presumably this continued onward. And the atrial pacing is at a rate of, let's say it's 80 beats per minute, just for the sake of conversation. So if you saw this in a patient, let's say the patient actually presented with 2-to-1 heart block, is this what you would mostly see in somebody following heart surgery, or would it be more suprahissian in the AV node? Where is the injury normally when someone has heart block related to heart surgery? Is it infrahissian or suprahissian when they come back and need to be paced?
It would be a guess, but I would say suprahissian.
Well, you had a 50-50.
Okay.
I got you wrong. No, it's infrahissian, usually. It could be suprahissian. It's not that you're wrong. It's just most of the time it would be infrahissian. And that kind of makes sense, right? Because if you think about it, the most common times that we see heart blocker when surgeons are closing VSDs, right?
VSDs or tetralogy.
Especially like very large VSDs.
Gotcha.
And so you would imagine, right, that the sutures of the VSD patch closure would be, going right into the Hiss or at least into the Purkinje fibers at the high septal region, which would be sort of below the AV node level, but at the Hiss Purkinje. So this is a much more serious form of heart block, right? And so if this were, for example, a patient who was coming back a month after heart surgery with this finding, we would be worried about this, and this would probably warrant a pacemaker because it would be beyond the 8 to 10 days following surgery.
Sure.
Similarly, if this happened during a cardiac cath, which is always possible, we would also be very worried about this because of the fact that it's infrahissian block, and we would normally recommend a pacemaker. Now, if this happened at the time of a cath, in other words, if the patient were conducting 100% of the time going into the cardiac cath lab, and then maybe you place a wire out the outflow tract and you see this, what do you think is the likelihood? So you come out of the lab, you pull the wire out, and you're still doing this, you're still 2 to 1. So, of course, you put a temporary pacing wire in the ventricle so the child has an adequate heart rate. And you go out and talk to the family and say, I'm sorry, Mr. and Mrs. Jones, but I've caused a 2 to 1 heart block in your child.
Yeah.
The first question that's going to obviously be asked is, well, what's going to happen, doctor? And what would you say? What is the likelihood if this were catheter induced from a catheterization? What is the chances that this is going to recover versus not recover and require a pacemaker? Again, if it happened at the time of a catheterization.
I think at the time of a catheterization, there's like sort of like the catheter may have irritated the area temporarily. So I would say that there's a good likelihood that it would recover on its own. If they asked for a number, I'd say greater than 70%.
Well, almost 100% correct,
Oh,
Dr. Conzen.
amazing.
We'll give you 100% credit on that. So it turns out that it's almost identical to surgery, that there's about a 2/3 chance that it will recover, just like in surgery, and a 1/3 chance that it will not.
Gotcha.
So we would actually watch and wait this out. Now,
Yeah.
I will make the argument, this is where I'm going to be a little self-congratulatory. I think that when somebody like myself or Dr. Love does a cath and sees this, that the incidence of recovery is greater. And I believe it's because we're much more sensitive to heart block and we pull the wires out when we see something like this. Like I have a very strong belief that part of the reason some people get permanent block, well, the most common is that there probably was a pre-existent injury that the wire just, maybe there was like 2 fibers left that got knocked off just by having a wire across it. But I also think that I have a strong belief that the longer the insulting catheter or wire is there, the more likely it's going to stay. So when I see this, I try to come out. Now, sometimes we're stuck, like, we might be putting a valve in somebody and we have, the 26 French sheath going out. And at that point, we're not going to stop unless the patient is arresting, of course. In other words, if the 26 French sheath is 3/4 of the way out the outflow tract and you get heart block, obviously no one's happy about that. But at that point, you really don't want to stop doing what you're doing. So we would probably, in that circumstance, work as fast as we can to deliver the valve and get the hell out of there. But generally speaking, though, if it's like during a diagnostic portion of the cath or whatever, you have to be careful about this. I remember when I started my career, when I was at Columbia, we used to do all of the balloon atrial septostomies exclusively under echo guidance. As you know, Dr. Love likes us to do them in the cath lab. So one of the problems with echo guidance for septostomy is that you can't see the catheter as well all the time. You have to be very careful and watch it go up the IVC and cross the septum and not just be willy-nilly advancing the catheter. And I was working with a fellow who I will not name, but who is now a very, 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 very prominent MRI expert. And accidentally, that fellow banged the catheter into the AV node, and that child was in heart block for like 9 days. And actually went to the OR, had the arterial switch and closure of the atrial septostomy lesion that we had created. Came back from the OR still in heart block, and 9 days later it all resolved. But it was
In the nick of time.
frightening, a little bit frightening. But again, because you can't see when you're doing it under ultrasound, one of the disadvantages is you can't see the back of the catheter. So chances are, if we were looking on fluoro, we would have pulled the catheter back immediately because we would have seen that we were doing something that obviously looked, improper on the on fluoro, but which you can't see the full course of the catheter as easily under echo guidance. And so anyway, lessons learned. Okay, good job. Thank you.
Great. Thank you so much.
All right. So couple of weeks ago, a fellow in the early morning sent me this delightful text. Good morning. I'm sharing blanks telemetry from midnight. Do you think it's EAT? So my question for you is this a reasonable question? And what is the answer? So why don't we ask Dr. Marshall what she thinks? I might add that this question was posed to me at 7 a.m. on a weekend, and this was from midnight. So right away, I would say reasonable, certainly after 8 o'clock, but there we go.
Good morning. So in terms of what I'm looking at the beginning of this strip, the heart rate's a little slower than 150. Looks like it's a little bit larger than 2 boxes. And then you see that it speeds up for about 1, 2, 3, 4, 5, 6, 8 beats or so.
Mhm.
And that looks like it's at slightly less than slightly faster than 150, because it looks like it's just a little bit less than 2 boxes. So I don't know,
Actually,
17.
yeah, it's probably closer to 180, 190.
Like I was gonna say like 170s or so.
Yeah.
So just it's like a little bit less than the 2 boxes. And then it goes back to again kind of similar that we see at the beginning of the tracing. And then in terms of trying to see, when thinking about EAT, trying to see if you can tell if you're seeing different P wave morphology, which on this tele to me it's a little hard to tell. I don't appreciate it looking dramatically different. So yeah, I mean, I guess my answer is it definitely goes from like 150s quick up to like 180 or so and then back down. So I guess my answer is it could be, but I'm not sure.
I would accept that with 100%. You get 100% on that answer. Right. It's very challenging to tell, right, from 2 leads of the electrocardiogram if this is EAT. It certainly is behaving like EAT.
Right.
How would you know it's not a reentrant arrhythmia, or what makes it seem unlikely to be a reentrant arrhythmia?
Is it that you're seeing this this increased rate, it appears to be terminating on a QRS versus a reentrant like P wave?
Well, you can't really tell. There could be a P wave buried in here. It doesn't seem like there is, but the baseline's kind of wide and the lines are a little. And what I'm looking at is just this is not perfectly regular. If you took the calipers, right?
Yeah,
The
sure.
R to R is not it. These look kind of the same, but I think
But the
this
first
RR
between the
is,
first 3 beats even look a little like that second beat there, yeah.
I think this RR might be a little shorter than say this RR. I mean, it's a very subtle difference. You would need to sit down with a caliper, but I think that there is some irregularity in the R to R intervals here. And so so that would go more with an automatic arrhythmia, and most reentrant arrhythmias we know usually have a fairly fixed R to R or a little more fixed than what we're seeing here. And I agree with you, Molly. These early beats here are especially different in the RR,
Yeah.
some of the later ones. So the answer is yes, reasonable question. Yes, possible EAT. Very hard to tell, though. I mean, if you look at the P wave morphology in this lead, it looks very similar, right, to the sinus P wave,
Mm-hmm.
right? Over here, it looks like in sinus rhythm, the P wave sort of has a negative deflection in whatever lead this is. Hard to tell what's going on here. Maybe you could make an argument that it's an upright P wave here.
Mm-hmm.
So maybe it is different and it is an EAT. Very challenging to know. This patient actually had a history of EAT, so a little easier in knowing that to say, yeah, possibly it is EAT.
Mm-hmm.
But point I'm really trying to make is that it's very important to review the tele, but sometimes it's hard to tell. But I think from the indirect evidence, history of EAT, an irregularity to it, the fact that it did stop suddenly, but it kind of sped up and then slowed down a little bit. Probably
Yeah.
goes with it being an automatic arrhythmia. Anyway, interesting. Or maybe not that interesting, but important. Okay, thank you. All right. This patient had an ASD closure, and this is the electrocardiogram in the office seen on postoperative day 10 for a post-op visit. The question is, what do you think is going on, and how would you manage this? So I'm going to ask, what do we ask Dr. Mukhopadhyay what she thinks?
Good morning, Dr. Pass.
Good morning.
I'm looking at the leads, looking at the rhythm strip.
Mhm.
The P wave is upright and it's followed by a QRS complex in the first one, not in the second one. And sorry, for the second one, it's pretty prolonged. For the first one itself, the PR interval is prolonged, appears to be prolonged. And for the second one, it appears to be more prolonged than the first one. And the QRS morphology is the same as the first one. And then I see another P wave superimposed on the T wave, and then no QRS after that. And then again, I see a P wave, QRS, and T. So the first beat is conducting, the second beat is conducting, but it's prolonged, and the third beat is not conducting. And yeah, and that seems to be how it's happening for the rest of the beats in that strip. So I would think, is this like a second degree heart block?
Well, so yes, I agree that this beat looks as if it's conducting. It might be. This beat, you're making the argument, is conducting with a mega PR interval. Am I understanding that right?
Yeah.
But the truth is, it's possible, but I'm just going to let you know, I've never seen a human being conduct PR that long. That's right. That's like over, let me see, 1, 2, 3, 4. That's almost a full second. So that's like 800 milliseconds or 900 millisecond PR interval. So it doesn't seem likely that the conduction would be conducting with this long. So I think this is actually not conducting at all. I can't guarantee that. It's impossible to know without an intracardiac catheter, but I don't think it's actually conducting. But I'm not going to say it's impossible. Then you have this P wave, as you rightly stated, that's sort of superimposed on the T wave that does not appear to be conducting at all. Then this P wave, if you measure this PR interval and this PR interval, they are not the same. This is the disadvantage of doing this on the computer, but I can assure you this PR is longer than this PR, making you wonder if this P wave is conducting as well. Then we see this P wave here, which is not superimposed on the T wave as this one is, and is kind of in the middle, sort of like this beat, I guess, not conducting. Then another one superimposed. Then we have this P wave. So it's possible. So I don't think this is conducting actually, unless this is, So one option is you say this is like the most impressive Wenke Bach of all time. Long PR, a really long PR, and then a non-conducted beat, a long PR, a really long PR, and then a non-conducted beat, PR, really long. So it's possible that this could be Wenke Bach. One of the things that goes against it also is that the R to R interval in this strip is pretty fixed. So you'd really want to see more. This is a somewhat unfair question from me because we don't have a rhythm strip, but in my defense, this was all I was given also. So you'd want to watch this and see if you see, one of the great clues to complete heart block is that the R to R interval is relatively fixed. You can't tell that on just, 5 or 6 beats, but so I think at best, this is some kind of high-grade second-degree heart block. At worst, this is complete heart block. Okay, so let's say the patient had an ASD device placed, and you're in the office and you're seeing this. Patient says they feel fine. What are you going to do about this? Or what should we do about this?
How old is the
I
patient?
should mention the patient went home conducting. We wouldn't have normally sent someone home not conducting. Let's say it's a 10-year-old.
So if I look at the RR interval, it's like 1, 2, 3, 4, 5, 6, 7, 8. The heart rate is around 37 to 40 beats per minute.
Yes, a little suboptimal.
Yeah, and the patient feels fine. And it's like a very low heart rate. And if it's I don't know, if the patient doesn't have any symptoms of syncope or I would monitor the patient, but if the patient continues to have something like this, then I'll probably put a pacemaker in.
So would you monitor the patient as an outpatient? Would you send them home and say, come back in like a week, or would you put them in the hospital and monitor them?
I would probably put a Zio in and see how they do. And if they continue to have like low heart rates in the high 30s, and I would probably ask them to come back.
So what I would say is if I saw this, I would absolutely admit this patient to the hospital. This is very unusual, right? We don't normally see heart block that develops late after a procedure. In other words, usually we expect that the conduction will get better over time when it's due to some kind of a procedural injury, such as ASD surgical closure or ASD catheter closure. We would expect that the conduction would improve. The fact that it's gotten worse is worrisome. And right, the way I would think about this is how we would think about a surgical case, right? If we had surgical heart block, we would not, even if the patient looked and felt well with a slow heart rate, we would not typically send them home. And the reason is because we would be worried that they could have a Stokes-Adams attack and just die. So normally we would admit somebody to the hospital to observe this because this is such an unusual finding to see after a procedure. And we really should not hang our hat on the fact that the patient is saying they feel okay. That's good, of course, but there's no guarantee that will remain the case. Sometimes in these circumstances, since it came late, and one theory might be that it's from inflammation. In other words, if you didn't see it originally, but you're seeing it with time, maybe there's some inflammatory process occurring around the edges of the device near to the either the AV node or the His Purkinje system. So sometimes some people would consider giving a patient like this high-dose steroids for a few days in an observed setting to see if it improves. One time early in my career, I had a patient in whom I did an ablation for AVNRT, and they, at that time we used to keep everybody overnight after ablation, and so we had 24 hours of telemetry showing completely normal conduction, normal PR interval. There was no problems in the cardiac cath lab. When they came back to see me a week later, the EKG looked something like this, and I almost fainted myself when I saw it. I was pretty upset. So in that circumstance, I actually did admit the patient, and I put him on high doses of Solumetrol, and it resolved. Now, was that because of the solumedrol or because of time? I don't really know, but when we see it, happen late after something like this, it would not be unreasonable to add solumedrol or steroid. Now, some people have wondered if in postoperative heart block should we do that. And there's been, I remember when I was a fellow, we actually had a protocol where we were going to give everybody ketorolac as an anti-inflammatory, but we just didn't have enough heart block to do the study. It was also very hard to get all the surgeons on board because these agents can sometimes, well, in the case of an NSAID, it can cause a bleeding. And although today, of course, we use that pretty routinely, but at the time it was a relatively new agent. You know, people have talked about giving steroids in that setting and whether it would change it. To my knowledge, there's not really any strong evidence that it helps, but I have heard of and seen multiple cases of people who late after catheter-related heart block who get later heart block. I have seen resolution or improvement. In my patient, what happened was the PR normalized. They were conducting 1-to-1, but interestingly, he always would wanky buck at heart rates that exceeded about 135 to 140 beats per minute. This happened almost 20 years ago, and to this day, he's still wanky bucks at about 140 to 150, but he has not required a pacemaker, at least not yet. So anyways, just an interesting observation. So if you see this, this is obviously concerning. Let me give you an example. Another example, just last week, we tried to close an ASD in somebody, and we were unable to do it because of a very large defect. And that patient did have a somewhat prolonged PR interval. In the lab, the PR went out to about 250. By the end of the case, it was about 180. The next day, it was also about 180. It would be very, very surprising. We didn't put the device in, we took it out. But if that patient came back a week or two later with heart block, we would be very concerned, but we would probably be hopeful that it was just an acute injury that would improve and that it was just inflammation, since we did see resolution in real time. All right, any questions about this?
No, thank you.
Thank you. So this is not an easy one, actually. It's not easy to tell with just this very brief strip what exactly we're looking at. All right, I think with that, we'll stop for this morning. Thank you for joining, and I hope everybody has a good day today.
Thanks, Dr. Paz.
Thank you
Thank
very much.
you.